and welcome to Voices of Wisdom, Tyro's podcast, designed to share thyroid cancer pearls of wisdom from clinicians for clinicians. You can think of it as kind of a fireside chat where we talk to international experts who share their wisdom and offer practical advice to clinicians in a variety of common and sometimes complex clinical scenarios. I'm your host, Dr. Dana Hartl. I'm a head and neck surgeon at the Gustave Roussy Cancer Center in France, and I am very excited to be your host of Tyro's Voices of Wisdom podcast. I will be hosting this second season of Voices of Wisdom, stepping into the shoes of Dr. Janice Pasica, who pioneered these podcasts. I want to take this opportunity to thank Janice for all of her hard work on making these podcasts a reality, and congratulate Janice and all of those who contributed to the success that they have become. In each podcast, we will be meeting with one or several international thyroid experts, and each episode will dive into a specific topic related to thyroid cancer care. Our aim is to help clinicians deal with issues that are often complex, and our aim is to provide as much evidence-based information as possible, but also practice-based information and tips from world-renowned experts. In each episode, I'm joined by a distinguished international guest who brings their unique perspective and expertise to the discussion. So whether you're a surgeon, an endocrinologist, a pathologist, a medical oncologist, or a nuclear medicine specialist, this podcast promises to be a pivotal resource in your quest for knowledge in the care of thyroid cancer patients. Welcome back to part 2 of this special episode of Voices of Wisdom. I'm Dr. Dana Hartl, and you've just joined us. We're continuing our fascinating conversation on unraveling the mystery and clarifying when, why, and how one should use radioactive iodine with Dr. David Pattison from the Royal Brisbane and Women's Hospital in Australia. In this segment, we'll explore more of this subject. If you haven't yet, I highly recommend listening to part 1 of this discussion to fully grasp the insights. So without further ado, let's dive right back in with our expert guest. So dosimetry does sound very complicated, time-consuming, complex, and really requires a very specialized center. And so you're saying that it's something that's really used for clinical trials to be as precise as possible. That's really important to know, I think. So on the biological level, you talked about beta arrays. And so how does radioactive iodine work as compared to, for example, external beam radiation therapy? Is that the same kind of mechanism?
Yeah, look, good question. It is very similar. And I like to think of, radioactive iodine or R131 as internally delivered radiotherapy. It's basically the same mechanism, but there are some important differences. And so following delivery of radiation, for example, via R131 therapy, cell death can either occur via apoptosis, after direct damage to the cell and sort of free radical generation, which occurs within hours of exposure. But there is also the impact via radiation-induced, reproductive failure from double-stranded DNA breaks, which can inhibit mitosis within the cells. And hence, more rapidly dividing cell types are more sensitive to radiation. And you may see response quite quickly, whereas the very well-differentiated tumours, you may actually see the impact of that R131 therapy occurring over many, many months, and sometimes it can take over a year to have the full effect of a dose of R131. And that's because that cell is undergoing mitosis more infrequently, and it's only when that occurs that those cells actually die and gradual reduction in size. Now, the difference is external radiotherapy involves high-energy X-rays, which are virtually shot into the patient from multiple directions, but in quite a complex way, targeting and centering on the tumor location. There's a dose map applied as a result of that, but there is still some toxicity in adjacent tissues along the pathway of where those X-rays are shot into the patient. And so that's best applied typically to one lesion or at most just a few lesions. Whereas the difference with I-131, which is typically administered orally, it's absorbed in the bloodstream, and based on its metabolism, it's then delivered to the site of the tumor, where it's taken up into thyroid follicular cells by the sodium iodide symporter. It's then retained within the follicle, and at that site, it delivers targeted radiation within just 1 to 2 millimeters at that site. Now, toxicity is both systemic and also in the other organs where iodine is concentrated. So you can also get some toxicity in salivary glands and lacrimal glands. And of course, as a result of that potential systemic toxicity, radioactive iodine is best for multifocal disease. If you can target something with external radiotherapy, like a local recurrence in the neck, you can get a higher dose locally, and you don't need to worry about the broader systemic toxicity. But in the setting where someone may have, miliary pulmonary metastatic disease or multifocal site, this is a very effective way of delivering radiation to what is often a radiosensitive tumor. One major difference, though, between external radiotherapy and radioactive iodine is the dose rate. So this is much faster with external beam radiotherapy, where those X-rays are shot through over a course of just sort of seconds, maybe up to minutes, versus in Theranostics or with radioactive iodine, where due to the half-life of radioactive iodine being 8 days, that radiation is delivered over a course of days to weeks. Now, what that means is that it allows much more time for DNA repair mechanisms to occur over that slow dose rate. And so hence, the same dose of radiation delivered is probably unlikely to have the same biological or clinical effect. So hence, when we extrapolate dose limits from external radiotherapy, like sometimes we talk about 23 gray to the kidney, these are unlikely to apply to Theranostics, where it probably is able to tolerate a much higher dose of radiation. But there's a lot of work being done in that space. But that's just one important difference between external radiotherapy and radioactive iodine. The other differences are perhaps a little bit more subtle, but they relate to heterogeneous dose distribution. So, external radiotherapy is just being shot straight through a tissue. It's pretty homogeneous across that organ that it passes through, whereas due to the short path length of those beta particles at a microscopic level, that can really influence the dosimetry and toxicity. And that's relevant in other areas of dosimetry, particularly, tumor damage to kidneys, for example, where the more radiosensitive areas may actually be further away from the doses delivered to them. And so anyway, it's a complex area of research, but it's just one of those differences.
So that's really important. It is kind of hard for us clinicians to understand when we're talking about grays and how much is actually delivered, and when we're talking about radioactive iodine as compared to radiation, external beam radiation that we talk about in other organs. So when we're delivering radioactive iodine, we hear about talking about ablation, we hear about adjuvant therapy. What are the differences, and what's your feeling about ablation?
Yeah, sure. So look, there are these terms. There's remnant ablation, and that's really talking about trying to destroy any remaining thyroid tissue, after a thyroidectomy. Look, we know surgeons do a great job, but it's impossible to remove everything. And in fact, sometimes it's reasonable for safety to leave a small remnant behind. Now, this used to be a goal of therapy, but with high sensitivity thyroglobulin monitoring, this is less necessary these days in order to follow up our patients. It's also important to recognize that in many of our patients, particularly with lower risk thyroid cancer, they can be cured by their surgery, and there's not a necessity to remove that remnant. And in fact, it's not really considered an oncologic outcome because it's normal thyroid that's left behind. Now, the other thing you mentioned briefly is adjuvant therapy. Now, the principle of this is to try to destroy any microscopic cancer cells that may be present in or adjacent to the thyroid remnant. And so that is patients with higher risk disease when we talk about sort of the ATA criteria and risk of recurrence, or potentially if patients may have a positive tumor margin, for example, in which case we're giving that higher dose of I-131 therapy to try to really target and destroy those cancer cells. So just to reiterate, we very rarely, if ever, administer I-131 purely for remnant ablation, because even in the setting of patients who've got elevated thyroglobulin antibodies, most of these can still be monitored for the trend of the thyroglobulin antibody, particularly if there's no other concerns and it's otherwise a low-risk thyroid cancer.
So another paradigm shift of not administering radioactive iodine all the time. I think that's a really important message. So thank you. And Another question before administering radioactive iodine, of course, we all know there's a kind of a preparation. Can you kind of go over what your practices and the indications for different types of stimulation?
Yeah, sure. And I kind of alluded to this earlier when we were talking about our approach. And the principle of TSH stimulation is really the need to increase the TSH level so that we can increase the expression of those sodium iodide symporters, which will optimize the uptake of iodine within tumors. Now, there's two ways to do that. We can do this using recombinant human TSH or thyrogen, where we give 2 injections, or we can do it via thyroxine withdrawal, which is dependent on pituitary function to endogenously increase the TSH secretion in response to hypothyroidism. Now, this is, of course, limited in the situation if a patient has pituitary failure or intolerance of hypothyroidism, such as major psychiatric disturbance or cardiac dysfunction. When we talk about recombinant human TSH stimulation or thyrogen, and when that's used with a 30 millicurie or 1 gigabecquerel dose of I-131, we know that approach has been proven effective and non-inferior to using thyroxine withdrawal and a higher dose, say of 100 millicuries or 3.7 gigabecquerels for the ablation of a thyroid remnant. So that's what we learned from the estimable studies from France and sort of from the high-low study out of the UK. They were published in 2012. It showed there was really no difference in the outcome, but it's critical to remember that that was in the setting of low risk, predominantly, except for the high-low study, low risk thyroid cancer, and there was no oncologic outcome in that initial RCT. It was powered to look for ablation of the thyroid remnant. And most importantly, though, we know that the use of thyrogen stimulation in that setting is associated with a better quality of life. Patients don't have hypothyroid symptoms. So it's quite reasonable when we're doing, certainly if there's remnant ablation, and also to a degree in patients with that lower intermediate risk, where we're really targeting the thyroid remnant plus or minus any microscopic cells in that setting. We're quite happy to use that approach of thyrogen and also a lower dose of I-131 therapy. We're not so sure about the longer term outcomes. There have been data from sort of 5 to 7 years follow up, but there were very small numbers of recurrences from those studies, and so there were no major glaring differences. But it's very difficult to be really clear. But by and large, no major differences, and so we're comfortable with that approach, and that's widely used around the world. However, it is quite different in the setting of metastatic disease, and so in this situation, there was a really pivotal study called the ThyroPET study, published in 2016. Now, this was a prospective multi-center trial across several sites in Europe, and the key question it was looking at is whether or not recombinant human TSH or a thyrogen-stimulated I-124 PET scan would predict what we would see on a thyroxine withdrawal-stimulated I-131 high-dose post-therapy scan. Okay, so a really important question. This would be fantastic if this trial was positive, because it would be so simple just to use thyrogen and an I-124 PET to guide all of our management for metastatic disease. But unfortunately, it was a negative trial. So this study was stopped very early after just 17 of 100 patients, because only 4 patients of the first 9 thyroxine withdrawal post-therapy scans that was positive on those scans actually had a positive finding on their I-124 PET. So fewer than half of the patients that had metastatic disease could be predicted from their thyrogen-stimulated I-124 PET. And in fact, there was a subset of patients who had 2 I-124 PETs, i.e. they had one with thyrogen, and then just before they received their I-131 therapy, when it was thyroxine withdrawal, they actually just threw in an I-124 PET there, and they found up to 20 times the dosimetry in some patients. So it really is quite a profound difference. And people have looked at, well, there's 2 variables. You've got thyrogen and thyroxine withdrawal, but you've also got I-124 PET and an I-131 high-dose post-therapy scan. But unfortunately, the discordance really is most likely due to the thyrogen, because when we look at the physical characteristics and resolution of I-124 and then the I-131 imaging characteristics, despite that much higher dose, when you do all the calculations, they're basically pretty similar. I-124 PET should be very similar. We also know that there have been studies done where you use I-124 PET with thyroxine withdrawal, and then in everyone you go on and do I-131 therapy with thyroxine withdrawal, and they're virtually exactly the same. There was a study published 2016, I think it was, and there were over 220 lesions looked at with 98% concordance. So I think it really is, in the setting of metastatic disease, I think it is important to use thyroxine withdrawal, if you're trying to optimize the dosimetry to those tumors. And what is the mechanism? Why is the difference? It probably relates to that in thyroid remnant, it's normal thyroid tissue. It's jam-packed with sodium iodide symporters. It functions like a normal organ. It responds very quickly to TSH stimulation. We get this rapid turn on and expression of that symporter, and therefore we get very good iodine uptake. With a thyroid cancer, by definition, it has already got reduced sodium iodide symporter expression. That's why they're called cold nodules on a thyroid uptake scan, because they don't behave the same. And it just takes much longer to get the wheels turning to get expression of those sodium iodide symporters. You really need up to a month. Now, the TSH level doesn't get up as high often, but you've got that area under the curve, of that TSH stimulation is occurring over a whole month as opposed to just over 2 days. And it just takes that long to drive that sodium iodide symporter expression. And that's my best explanation for why I think we see this difference. And that's really why in our approach, we always use, in the setting of metastatic disease, if we're doing an I-124 PET, we do use thyroxine withdrawal. I wish it wasn't the case. I wish I could just use Thyrogen because it's so much more simple and our patients love it. It's so much better tolerated. But unfortunately, that's just the approach that we use, and it means we have to book a bed at the time of the I-124 PET. We only do that PET scan when we'd be prepared to treat a patient, and there's quite a sequence involved. But yeah, that's our approach to use of. We use Thyrogen in most of our patients, but just in those metastatic cases, we have that different approach.
That's great. You talked previously about toxicity, and we know that radiation can induce cancers later on. Do you screen patients, or do you think patients should be screened once they've had radioactive iodine? Should they be screened later on for other radiation-induced tumors?
Look, that's a really good, it's a good question. It's something that's been looked at a lot in a variety of studies and some meta-analyses. The short answer is we don't screen patients for secondary malignancy. I think in the data that's been shown, there is some uncertainty around the precise risk. There are several studies that have shown a very low relative risk of some secondary malignancies, including in some cases, AML or CML, some hematologic malignancies. Other studies have actually shown a consistent reduction in risk of myeloma. So there is some discordance there. And in solid tumors, there has been suggestion of stomach, colorectal, and kidney tumors. But it's one of those things that there's a very low risk, and there's not a consistent finding across studies. So some studies have shown a signal, and others, including some large meta-analyses, haven't. And so it's not something that there are any guidelines about recommending screening. Particularly, the main setting would be patients who've had very high cumulative doses of radioactive iodine. So in patients who've had over 1,000 millicuries or over 37 gigabecquerels, there are recommendations about monitoring for myelosuppression, like a direct effect on the marrow. But with other treatments available, it's very rare for patients to get anywhere near those sort of radioactive iodine doses these days. So, however, so there is some uncertainty there. Really, what it comes down to is a risk-benefit analysis in every patient. And I think this is behind that trend where if a patient doesn't really need radioactive iodine, we don't treat them. We don't treat low-risk patients anymore. We don't use that goal of remnant ablation. But once the patient's disease goes above a threshold, and that's really at intermediate risk, we start to think, well, they do have a cancer. There is a potential benefit from having radioactive iodine. What is the most appropriate treatment for this patient using those guidelines? And we use this principle. It's called ALARA, which is as low as reasonably achievable. And that's part of the reason why we're continually seeking to optimize our treatment to those patients who are most likely to benefit from radioactive iodine therapy.
That's very clear also, David. Thank you. We've seen so recently this paradigm shifts. And how do you see the future of radioactive iodine therapy? Are there technological improvements coming up? What's on the horizon?
I think really our key goal is personalized treatment, as in many areas of medicine. So it's really minimizing the use of radioactive iodine in patients who are unlikely to benefit, and then optimizing our use of radioactive iodine in those patients who we think will benefit. And typically, that's most important, I think, in being able to even escalate care in those who've got metastatic structural disease, where those benefits are far more likely to outweigh any risks. And ways to do this include, patient selection for that cohort with I124 PET. There's some other genetic markers that are looking at, iodine or radiation sensitivity within tumors. The use of thyroglobulin to tailor and predict those patients who are more likely to have significant disease. And another very interesting area, which I've got a particular interest in, is re-differentiation therapy in selected patients. And then also considering some other theranostic targets, including something called FAPI, or fibroblast activating protein inhibitor. So re-differentiation therapy, I think that's a really exciting opportunity, although its role really is yet to be, firmly confirmed in clinical trials. I see the main role of re-differentiation therapy as being an opportunity for a bridge between those patients benefiting from radioactive iodine before commencing tyrosine kinase inhibitor therapy. And I think it's particularly of benefit in those patients who've had slowly progressive or previously I131 avid disease, which has become radioiodine refractory. And these cohorts of patients, I think, are more likely to respond, rather than those patients who have got much more aggressive or intensely FDG avid disease that have never taken up radioactive iodine. It's just a step too far to try to turn on all that machinery again and get it to take up radioactive iodine. So we're conducting the iFirst trial in Australia, which is a multi-center trial, which is using I124 PET dosimetry in all patients, TSH stimulation with thyroid hormone withdrawal, and they either receive re-differentiation with trametinib in patients with NRAS mutations, or the combination of dabrafenib and trametinib in patients with BRAF V600E mutant tumors. And so it's going to be very interesting. It's a slightly different protocol because we're the first protocol that actually uses thyroxine withdrawal in this setting. But yeah, this trial's been underway for just over the last 12 months, and we're accruing patients, and yeah, we should get results in the next 1 to 2 years.
Well, that's really exciting. As you guys say, good on ya.
Yeah,
that's really exciting. We're really looking forward to seeing those results. So to wrap up all this, it's really exciting and fascinating information. Do you have one take-home message for our listeners today?
Look, probably one take-home message would be to engage with your local nuclear medicine specialist. So I think, if you're treating thyroid cancer, it's important to have a reasonably close collegiate relationship with your local nuclear medicine specialist. Find out what their approach is, ask the right questions to sort of discuss how you manage patients within your center. It's important to recognize there are some differences in thyroid cancer management around the world based on institutional practice, but hopefully we're going to have some clinical trials which will continue to guide the path forward to answer some of these questions.
Thank you, Dr. David Pattison, speaking to us from Brisbane, Australia. That wraps up this episode, Radioactive Iodine, Unraveling the Mystery. Thank you again so much, David Pattison, for being our guest today.
No worries, Dana. You're welcome. Thanks very much for the opportunity to speak today.
And that officially concludes our extended discussion on unraveling the mystery and clarifying when, why, and how one should use radioactive iodine. I'm Dr. Dana Hartl, and it has been a pleasure to delve deeper into today's subject with Dr. David Pattison. Thank you, David, for sharing your invaluable expertise and enriching our understanding. If you have any questions or suggestions for future podcasts, please email us at voicesofwisdompodcast@gmail.com. We have an exciting season ahead of us. Please stay tuned for future episodes where we will discuss topics like what is oncocytic thyroid cancer, what is unresectable thyroid cancer, just to name a few. And if you liked our podcast, please subscribe to our webinars, which air live every Friday morning at 8 a.m. Eastern Time. Thyro Multidisciplinary Seminars is a series for thyroid clinicians and researchers that covers breakthroughs in thyroid cancer research and treatment in the form of topical journal clubs, state-of-the-art lectures, multidisciplinary tumor boards, and lively panel discussions. So just visit thyro.expert/subscribe or click in the link in the description. Thank you for tuning in to this episode of Thyro's Voices of Wisdom podcast. Join us next time, and in the meantime, take care, everybody.